Good evening. I'd like to talk about trauma, and this is a subject that's quite close to my heart because we all go through trauma, but we all don't have a disease or an illness because of trauma. The definition of trauma is a psychological distress following exposure to something, and it's very variable. All of us experience it differently. If we are experiencing it, can be anxiety or fear, or it can be anhedonia, which means you're not interested in anything, or a dysphoric depression, where nothing is good enough, or you can have anger or aggression. So this is the three main things what trauma can do to us. There's different kinds of trauma. Please remember, it's only abnormal. You only experience it abnormal if it's significant influence your time after X amount of time. If you've lost somebody, it is normal to grieve for 6 months or even more. And if it doesn't influence your life, you're able to work, you're able to have relationships, but you are sad, it is not an illness. Some reactions to trauma are very normal. And it needs to be, the normality needs to be different from what we see as an illness. In trauma, it has to be an illness that is not due to another illness, so it can't be due to depression or bipolar, and the symptoms are not due to substance abuse. The best treatment for trauma is therapy, not medication, and definitely not drugs. There's two big trauma things in childhood: reactive attachment disorder and disinhibited social engagement disorder. This happened in very early childhood, in the first few months, and long term, it can give you dissociated identity disorder, bipolar mood disorder, PTSD, generalized anxiety, borderline personality disorder. This is very rare. This is not something we see often. This is when children are in a children's home and have very few actual contact. Post-traumatic stress disorder. This can happen in young children and adults. For time's sake, I'm only going to look at the adult criteria. The first few slides is literally just going to give you criteria and definitions so that we know what we're talking about. In the criteria, you have a criteria A to a criteria H, and you have to have at least some of these in order to have post-traumatic stress. So you have to have direct exposure, or somebody, a close friend or a close relative must tell you about it. And it must be a violent or accidental death. So you can't get post-traumatic stress disorder if there is a cancer, somebody dying from cancer. That doesn't give you PTSD. It needs to be violent or accidental. The experience needs to be repeat exposure. Repeated experiences often happens with social workers that repeatedly is exposed to child abuse, even therapists that repeatedly hear trauma. That also can cause PTSD, but that doesn't cause PTSD if it's in a normal life. The exposure cannot be via electronic media. So it's not a game, it's not what you read, it's not a movie, that cannot give you PTSD. It's a direct exposure to you or to a friend or a close relative that tells you about it. Criteria B, you have to have at least one of this, is you have to have intrusive distressing memories. These memories must be a few times a day that they come when you're not thinking about it. Recurrent distressing dreams, a dissociated reaction, which is flashbacks. A flashback is not when you just think about something. It's when you literally is back in the position, experiencing, having the anxiety, seeing what's happening to you, running away like you would run away from a trauma. And then internal or external exposures cause severe psychological distress. So this is important, and this is part of post-traumatic stress disorder. People miss this because they think, yeah, if I went through a car hijacking or a murder, I have PTSD. You have to have these criteria to have PTSD. You also have to avoid the memories, thoughts, or feelings, or avoid the places, people, and conversations. So people literally will drive 100 kilometers just not to drive through this. You can drive through the things, there's no avoidance, it's not PTSD. Criteria D is that you need to have negative mood, and you have to have two of these: inability to remember important aspects of the trauma, exaggerated negative belief, expectations about oneself or others, and persistent distorted cognition that you think that the world's going to end, you're going to die, and a persistent depression, and nothing is nice anymore. If you can experience anything nice and you can laugh and it's a joke, then you don't have anhedonia. E is you have to have two, either very angry or reckless and self-destructive, hypervigilant, exaggerated startle response, not just a normal startle response, problems concentrating, and sleep disturbance. I know this is a lot of symptoms, but what I actually am trying to show to you is that it needs to be there for more than a month. You have to have an impairment. So you are unable to work, unable to socialize. There has to be an impairment, and it's not due to substances. So you can't get PTSD if the symptoms are due to substances. And if you look at these criteria, it's not easy to have all of them. So PTSD is a very difficult diagnosis and is very seldom. About 8% of people in their entire life will have an acute stress response. PTSD will be around 2% of people in their entire life. So it can happen from 1 year. It can take years to develop, but normally there's symptoms within a month. And it can lead to other illnesses, but it is the other illnesses who should not be the major and the first thing. So it can have depression and bipolar, and it can lead to that. But people often have that and PTSD. So you have to know that the PTSD symptoms need to be more than the symptoms before the event, and it needs to be significantly more. And what is PTSD caused? It leads to poor relationships, educational problems, abstinence at work, lower income, and physical symptoms. This is acute stress disorder. As I said, I'm going quickly through the first so that we just have a basic viewpoint. This happens before PTSD, so it happens 3 days after the event and in the first month. This does not lead to PTSD. It has similar symptoms, but it doesn't lead to PTSD. So again, it's the same as PTSD, direct exposure, or somebody close to you needs to tell you. It needs to be violent or accidental. And then that it does not electronic media, it's not a movie. With acute stress disorder, all those millions of criteria from PTSD are actually all in one category with acute stress disorder, and you have to have 9 of them. You can have my slides afterwards if you want to read back the extra specific things, but you have 9 out of all of these symptoms in order for PTSD to happen. And it's the same symptoms that we went through with PTSD and acute stress disorder. Arousal, not sleeping, hypervigilance, and then, it's not due to substances. If you had depression beforehand, this must be markedly more. And you definitely should be at a place where you cannot work, you cannot do things. Less than 20% of traumatic cases have acute stress disorder. If there is not a personal assault, so if it's not rape or assault or witnessing a mass shooting, it's a very low percentage that people get. Assault, rape, and mass shooting has a 50% chance of developing acute stress disorder, but accidents, burns, even car crashes has much lower chances. It's 13% or 10% that develop acute stress disorder. 50% of that can develop PTSD. So if you consider that it's about 20% of people that went through a stress disorder that can develop acute stress disorder, and they have to have those symptoms, about 10% of those people might develop PTSD. PTSD is something, though, that gets better, no? The human being is remarkably resilient. In severe traumatic events, only 50% develop acute stress disorder, and that's severe traumatic events, no? And only 50%, 25% of the total, develop PTSD. 8% of the population over a lifetime can get PTSD, and PTSD can get better. Here is one of the main things that I want you to hear. The treatment to prevent PTSD is not getting a sleeping tablet or a calming tablet or a benzodiazepine from your GP. If you sleep or you calm down or you get Ativan, it increases the risk for PTSD. The only thing that actually has proven to work is a beta blocker like propranolol, Inderol, that prevents the PTSD. But the sleeping and calming tablets, the tranquilizers, all the GPs give if something bad happens, that actually increase your risk. If you go to bed, it increases your risk. So it's normal to be awake and to talk to people after something happens. Your memory are formed when you sleep. So if you take a sleeping tablet after such an event or a calming tablet, it actually cements the memory. So it's normal to stay awake and everybody talks to each other and talk about it. That's how people normally respond to trauma. Trying to knock somebody out always will make it worse. So a lot of people don't have PTSD. So people come and sit in my chair and they say they have PTSD or acute stress disorder, and very few people actually have it. The people probably have complicated bereavement and grief if they lost somebody. The people that are bullied also tell me they have PTSD, but they were bullied. If you are stolen from without the risk of being killed, it's not PTSD. Car crashes where nobody dies, not PTSD. The ones that have only some of the symptoms, but not all of them, it's not PTSD. And if you had another diagnosis like depression or bipolar or substance abuse, and you don't get worse, the symptoms stay the same, it's not PTSD. So often people sit in my chair and they say, no, I have such trauma and flashbacks. But the flashback is actually memories. It doesn't happen once a day or twice a day, it just happens sometimes. Or they're missing somebody because they died and they have bereavement. Or I've got PTSD because people bullied me at school. No, that's not PTSD. These things does not cause PTSD. In South Africa, everybody tells you they have PTSD, and very few people actually have it. We have to look at what's normal. It is normal to cry when you're overwhelmed for any reason. Cheryl once told me something that is really remarkable. She said, you must cry as much as you laugh, because both are equal emotions. You have to have the negative emotion and you have the positive emotion. It is normal to grieve, to miss somebody. It is normal to feel angry, scared, or irritable. People around to die. This does not cause trauma. That's caused grief. If your mom dies when you're a 6-year-old in front of you to an accident, that definitely is PTSD. But if your mom dies when you're in your 20s from cancer, it will not cause PTSD. Both are traumatic, both make you sad, but they do not cause PTSD. Each person responds differently. Your culture also needs to be taken into account. If your culture is that you have a month of severe mourning, that does not make it a complicated acute stress disorder. So what I'm actually telling you is a lot of things that we experience is normal, and we see that as abnormal. We see grief as abnormal. It's normal to cry. We see being scared or irritable as abnormal. No, that's normal. And we can't treat normality. One of the things that we often use to put everything in is adjustment disorders. So that is when your emotional behavioral symptoms to a stressor, which might be a death, within 3 months of when the stressors start, is not quite normal. But it's not severe enough to be depression. It's not severe enough to be anxiety disorder. You just have difficulty adjusting to it. So adjustment disorder is one of the other trauma disorders, but it's not as severe as acute stress disorder or post-traumatic stress disorder. There's marked distress out of proportion of the severity. So if somebody dies, you can be severely distressed. Adjustment disorder is just when it's more than normal. It's not normality. We can't treat normality. We have to look at the context and cultural factors, and they need to be significant impairment. And that is part of the psychiatric diagnosis of all the disorders, is significant impairment. You must have trouble studying, you must have trouble having relationships, trouble working. There must be an impairment, else it's not an illness. and then it does not meet the criteria for depression or anything else. So adjustment disorder is often what people have when they tell me they've got post-traumatic stress disorder. So they are not adjusting well to what happened, but they don't have the severity of PTSD. PTSD is very severe, people. People literally cannot have a full day work. They cannot sit and talk to you without having memory flashes. So the adjustment disorder has different kinds. So you can have a depressed mood, anxiety, you can act wrong, you can be emotions and conduct, and they're not enough to have a diagnosis. So adjustment disorders is mostly the people that sit in front of me and tells me they have PTSD. They don't have full enough criteria for depression or bipolar, but they are depressed and they're not coping with what happened. It is a completely different thing than post-traumatic stress disorder. There's two new kids in trauma on the block: complex post-traumatic stress disorder and persistent grief disorder. None of these criteria is fixed yet. They're looking at it. Complex post-traumatic stress disorder is when you have PTSD and there's a repeated trauma which causes severe anger. Severe anger is breaking down places, breaking doors, It's not when you're high, it's not when you're on drugs or alcohol and then anger. It's when you are no alcohol, no drugs, but treat as if you are on drugs, if you act like it. And difficult to control your emotions. So that's complex post-traumatic stress disorder. People often say, I've got complex post-traumatic stress disorder because I went through so many traumas. No, you have to have all the post-traumatic stress disorder things, plus repeated trauma, plus you must be so severe that you knock doors and kill plants and throw cups and saucers. It is not something that's just mild. Normal bereavement and persistent complex bereavement. Here's the things that I want you guys to listen, because this is what I hear over and over. The patient sits by me and says, I've got post-traumatic stress disorder because my grandma died. Okay, how close were you to your grandma? No, I saw her only once a year. Okay. And do you go to school? Yeah. Do you have family? Yeah. You do not have post-traumatic stress disorder, and you don't even have persistent complex bereavement. Persistent bereavement is if the dysfunction is more than 6 months after somebody died. So for 6 months after somebody died, you can only focus on the grief. You cannot function. You can feel that the loved one's death is abnormal. And 10% of people experience grief. Not many people experience persistent complex bereavement, because that means you actually can't cope after 6 months. It is normal to cry. It is normal to do your work and not go out with people. Those things are normal. It's normal to cry every day if you lost somebody for at least 6 months. So I'm actually going to start talking now with Cheryl, because those first slides you're welcome to have, but it was just to explain to you that what I see is often normal behavior and normal responses to trauma. This is not what I see in my practice. I very seldom see PTSD. I might have seen 3 this year. It's not a lot. I see some acute stress disorders and I see adjustment disorders, but real PTSD, I might have seen 3 years this year. They're very rare. And I see probably 3 people a week that tells me they have it. Let's talk about grief. The 5 stages of grief was started by, this is just if you have complex bereavement, intense yearning, can't cope, can't work, only thinks about the person, emptiness, loneliness, life is unfair and meaningless. And then at least you need to be shocked or stunned or numb. And this needs to be at least 6 months after somebody died. Else this is normal. Anger or bitterness, hearing and feeling the pain that the person saw. So if they died from cancer, you feel as if you have cancer. Not trusting other people, intense reaction to memories or reminders, avoidance of excessive seeking reminders. This, guys, is 6 months after you lost somebody. And like all things, it needs to be so severe that you actually cannot work or cannot have a relationship or barely functions at work. The stages of grief, Elizabeth Kubler-Ross started with the stages of grief in a book on death and dying. This is only one of many theories, and this one has been proven to be true and proven to be not true, and it's a theory. So I'd like to go through the stages of grief because it has some benefit for you guys, because I think that a lot of the addicts go through stages of grief about their drugs. They respond out of grief for their drugs. Denial is they deny the reality, withdrawing from people who believe the reality. Fearful of accepting death or stopping the drugs. In our almost clean world, we no longer see people dying. It used to happen that grandma died in the house, etc. But now we send the people to hospice, in hospitals, and we are not present when people are dying. So we often get stuck in denial. How did people die? You haven't seen it, so the denial is there. Maybe people didn't die. So the way looking at the denial is to actually have rituals. So some of our countrymen have rituals where they putting up headstones or they sit for a month in the house. And this helps us to experience and to work at the denial so that we don't get stuck in the denial. We often don't have rituals nowadays, so we have to actually probably make our own rituals. I know how many people that die and people don't even go to the funeral if they don't have a funeral. So if we miss somebody, we need to establish our own rituals to prevent us from denying it. So writing letters to the person and putting it with a photo of them, planting a tree to remember the person with, going to sit and looking at a photo, those are rituals that can help us so that we don't deny. Being in rehab is seen as a ritual. So the ritual of I am breaking my denial that drugs are bad. So in rehab or therapy, it's a ritual so that we don't get to where we deny that drugs isn't good for us. We actually have to start seeing the reality of drugs. Anger is lashing out at people, and this is quite normal. We should allow people to experience this, but people get stuck here. They get angry at the sister who was looking after mum because the sister didn't respond quick enough. They actually often blame medical staff and even sued, or the anesthesiologist that was killed 3 years ago because the person died and the family was sure that the medical staff caused it. So the inability to accept the loss of control is often seen here. The patients always say, you want me to stop. My parents are the worst people in the universe because they put me in rehab. Rehab is just a money game. The amount of times I hear that sentence is unbelievable. And then if you look at how much the people pay, then it's like you pay less than most hospitals. Life isn't perfect, and neither should it be. That is the answer to anger. We cannot be angry because life is not perfect. Life is not perfect. We do not get everything right. Perfectionists and over-controlling individuals often are hugely angry. And you need therapy if you're stuck in anger, either because of the drugs or because of somebody died. And it's literally that from, you know what, the doctor didn't do their best. And sometimes maybe the doctor didn't do their best. But, sometimes they did. And they probably did more than you think. And we cannot get stuck in this because then we do not get to acceptance of grief. Bargaining, this we see so often in the rehab. What if I promise to stop using, will you let my mum live longer? My best wish is that you would stop using. I know my mum has died, but would you let my dad live if I will be good. I will only drink on my birthdays. That is so often. I see that so often in the rehab. I will start drinking in 5 years' time. That bargaining before they accept that they are an addict is huge. Using bargaining to get your loved one to do something will only cause trouble long time. So if you say, you need to stop, and if you stop, I will send you to Switzerland. That's bargaining, and you will get into trouble. Depression is the next part of the pillars. I'm going to die. Why should I bother even stopping? I'm really not. Nothing will be good again. If I stop drugs, nothing will be good again. My life is my drugs. You don't understand. I can't use. There's nothing for me except using. I would rather die. I see this probably in most of my patients at one stage, because they go through the stages, and the stages isn't linear. So they go from anger over to depression and back to denial. But this is a process. So it's not just a process when people die. It's also a process when our patients stop using. The acceptance side, it will be okay. I can prepare for life now. I realize I need therapy. I realize I need to stop my drugs. And if our patients can't get here, they can't get better. There are other theories that I find helpful in trauma and grief: resilience and positive psychology, and good enough from Winnicott. The resilience is that the ability to respond to trauma is related to how we look after ourselves and how we think. And resilience is also the ability not to get ill. And this is a big thing. How do we teach our children resilience? We need to teach them to get connected with society, get connected with friends, get connected with family. We have to make every day meaningful. So don't go through days that it's meaningless. You have to do something every day that makes it special. Learn from experience. So learn from not using drugs, learn from not fighting with people, remain hopeful, taking care of yourself. You can't be resilient if you don't sleep enough. Can't be resilient if you don't exercise and eat right. And be proactive. So if something bad happens, go and speak with the family. Go and speak with your therapist. Be proactive. Because these things enable you to go on. And this is one of the things that I least likely see in our patients. They're often not connected. They're isolated, use on their own. Every day is just the same for them. They don't make a day meaningful. They often don't learn from experience. They're very hopeless. They just don't take care of themselves. So in order for your child to be better, this is what you need to do. And you need to model this for your child. So your child needs to see that you are connected with friends. Your child needs to see that you do something meaningful every day, that you learn from experience and don't repeat mistakes, because this will get them to manage and to go on. There's the movie Happy, which is positive psychology. It is Happy, the documentary. It was done not in the field of addiction, but the 12 steps fit so well with it. So this was done in what makes people happy, what makes people healthy. And 50% of it is medication and genetics and illness. If you don't have an illness and your 50% is good without an illness, it's good. If you have an illness, 50% of people need to have that treated. 10% of what happen is circumstances. It's often get used as the reason why people are addicts. They say it's because of my circumstances. If I had more money, if my mom was better, but it's only 10% of what happens. It's not more. 40% is choice. So choice is, what do I do to make myself happy and healthy? And here's where the 12 steps come in, because except for one, the rest is pretty much 12 step. So although it comes from two completely different theoretically bases, it actually comes down to the same thing. And it's a gratitude diary, being grateful for things every day. Take a screenshot of this, please, because this is what you need to do to be healthy and to be well. Need to exercise 10 to 20 minutes a day. It's not a lot. You can do it in chunks, like exercising 40 minutes every second day. You need support with family, friends, and therapy and meeting. Don't isolate. Variety as much as possible. Eat different food. Wear the clothing in the back of your cupboard. Watch nature, how it grows. This is the one thing that's not part of the 12-step. The rest are. But this is the things from completely different side that makes people happy. And I think that this is the things that makes you happy. Flow, it's an hour a day of intense concentration to the exclusion of everything else where time is lost. So that's meditating, praying. It's when you hit that zone when you exercise, coloring, hobbies. It's not TV, not reading, and not music. So it's literally sitting and doing something in a meditative fashion. I have difficulty with flow. So if I don't draw, I probably play a mindless video game like Tetris, because that's intense concentration and it excludes everything else. Flow is the one that's an hour a day. So it's the one that takes the longest. But you can divide it into 2 or 3 sessions. So you can do 20 minutes here, 20 minutes there, but flow is the one thing that you have to do. So flow, often some types of step work can be seen as flow, some not. But flow is one of those things that you just have to do. You have to live in the now. And then random acts of kindness. This is the one thing that I've seen all South Africans do. We all make coffee for each other. We all let somebody else walk before us in the door. I very seldom see random acts of kindness that we don't do in South Africa. But we don't do flow and we don't do variety. And we need to do that in addiction or even non-addiction, because this is positive psychology, which is non-addiction. This is the things that we need to do. And then there's Donald Winnicott. And this is the other thing that looks at trauma. It's a good enough. The key function of good enough parenting is to provide the essential background to allow for the growing child's disillusionment with the parents and the world. So you need to not overprotect your child. You need to allow them to make mistakes and to see that you can make mistakes without destroying their appetite for life and ability to accept external and internal reality. So you have to keep them positive, but you need to allow them to make mistakes. By surviving the child's anger and frustration with the necessary disillusionment of life, the good enough parents would enable their child to relate to them on an ongoing and more realistic basis. The good enough environment provision, which makes it possible for the offspring to cope with the immense shock of loss of omnipotence. If you prevent your patient and your loved one from not experiencing bad stuff, if you put them in a little bit of cotton wool and they have everything is perfect about them, you're actually creating a person who can't be happy. In order for people to be happy, they need to have things that doesn't work out. Failing such provision, family interactions may be based on a fantasy bond in a retreat from genuine relating that fosters this false sense and undergut of this, I am perfect and parents are perfect. And if you don't allow your child to make mistakes and you don't allow your child to go through bad stuff, you actually are damaging the child. And codependency is often when people try to be perfect. So, protecting from everything, you will destroy your child's happy and healthiness. Parents often say to me, I can't put my son in rehab. Or if my child complains, I have to rescue them. This is enabling, but it's also putting your kid in a place where they never can be happy. They have to go through bad stuff to be happy. It's often the parent that the addict idolizes and that they think is perfect that is enabling their child. And if you are enabling your child, they cannot manage in life. You have to allow them to experience bad stuff. And this is one of the major things. If I see, it's my child, Dr. Thea, I can't do this. I hear you, but not allowing them to make mistakes and to experience consequences of what they do will make them unhappy, ill human beings. To be happy, you need to allow people to have consequences and to experience life. As you can see, lots of the current social media and views of people see normality as an illness. They say you've got PTSD where you actually don't. You just go through a normal response. We can quick say that we or others have PTSD. And although some people do have PTSD, most of the people in my practice have normal responses to trauma and they don't have PTSD. But even people with normal responses to trauma needs to talk to people about it. That's how we, for years and hundreds of years, did. You should talk to your family if something bad happened. You talk to your friends. And in the isolation where we are now, we don't talk. So talk to family, friends. If there is nobody else, talk to a therapist. But this is normality. This is managing a normal reaction. We do not treat normality. I don't give medication for normality, but I absolutely treat illness. And I know that it's always difficult for the people to hear it, especially if their children are on medication. I do not give all my patients medication. There's people that walks out of my office without medication. But I will absolutely treat illness. Lots of the treatments for trauma is psychotherapy. It is not medication. I will refer them to a psychologist and they're like, oh no, I have to go for 6 sessions. Yes, because medication doesn't work for it. My favorite trauma therapy is BWRT. It is one of the therapies that Changes do. When it started, my sister's a psychologist and she wanted to give BWRT to one of my patients. And I said, not on your life because I don't understand it. So I went for the training and I actually understand why it's working, although the people told me a completely different reason why it's working. I don't believe what they said because physiologically mine makes sense. There's a bit of a idealistic viewpoint, but it completely makes sense why it works. And trauma is often used as an excuse for using substances. And although it can influence substance abuse and worsen substance abuse, I very seldom see that as the reason for substance abuse. But every single patient in my room said, I'm using because my grandma died. I'm using because I asked them, why are you using? And all of them has a traumatic reason why they're using. But it's normal stuff, like my grandma died. It's normal. It is more likely that they're using because you have overprotected them and you have not allowed them to become human beings that can do these things. So if you are a too perfect mother and you don't allow people to experience bad things, you are probably part of the reason your child's using. Don't be perfect. Allow them to experience their stuff. Thanks, guys. I know it's a lot that I said, but I said the first win is more that you can see that post-traumatic stress and acute stress disorder is very specific. That's not what most people have. But that doesn't mean you couldn't talk to people about it and shouldn't do therapy about normal trauma, because we don't sit around the fire anymore and tell stories. So we often need a therapist to tell the story to, because we don't do it.
Yeah, great presentation. So much came up. I think, what was just resonating for me is all the reasons we hear on a daily basis of why people use. And it often is. It's trauma, it's PTSD, it's my parents, it's my school, I was bullied. And, we try and explain to our patients, who are most of your loved ones, your kids, that wasn't the sole reason. Most people picked up substances through experimentation, curiosity, availability. And a lot of people caused trauma in their active addiction to themselves and definitely to their families. And I often have to use this scenario, and I hope I'm not breaking the lady's anonymity, but she does a lot of talking. The lady Allison that had her throat cut in PE, I think. She never took drugs. She never used substances to help her cope. She went for loads and loads and loads of therapy. And that's a very severe case of trauma. It's horrific. It's unimaginable. But she never needed to use drugs to escape that. And I often
Drugs
have to
doesn't work.
that analogy with a lot of our patients because they need to believe, or it's part of the blame, that I use because my mother died, I use because they got divorced, I use because I lost. I've yet to meet a addict who hasn't had trauma, but the trauma isn't the cause for that addiction. And I think that's quite shocking for everybody present tonight because we've listened to our loved ones' stories and blames and repetitive, I use because. I often joke with my team and I say, when somebody tells me I use because I'm an addict, I think I'll buy them a cake. Because they don't use that. They don't say I use because I like drugs and I'm a drug addict. And that's why they use. And of course, there's other factors, but if they didn't like the effects of narcotics, they would carry on using. So thank you very much for that. We have one question, and then I'm sure people are going to ask more. Hi, Dr. T. Is BWRT connected to cognitive behavioral therapy?
Yes and no. Cognitive behavioral therapy went further into EMDR, etc., and BWRT is a combination of EMDR and cognitive behavioral therapy. So it used principles from both sides, but it's not specifically cognitive behavioral therapy. It was actually started by a South African and a British guy. And because of that, I really thought that this is nonsense, but it's not. It works in the effect that you connect different emotions to the trauma. And if you connect different emotions, then it's not that traumatic. So you don't forget your story, but the emotions change.
From our perspective at Changes, it's proven to be revolutionary because we can use it at most stages of their treatment. And it's not because trauma talk therapy can take months or years.
And it might make you worse.
Yeah.
Trauma talk therapy might make you worse.
And in most cases, definitely worse before you get better. And a lot of times you have to work, you have to partake in a family. So what I like about BWRT, it's instant. Within that session, it's held, and then they can process it without that fragmentation of collapsing in grief. So yeah, if any of you do know BWRT, it is amazing. It's revolutionary.
The interesting thing is that people who started it said there's one type of patient that you can't do it on, and it's the patient that goes to court, because they will stand in court and tell their story without crying, and nobody would believe that it's that bad, because they have disconnected the emotional part and they don't cry and they're fine without it. So you cannot use that. He literally says, please don't use it if somebody is going to court, because nobody, the court, the judge, nobody will believe that they actually went through trauma, because they won't look that way and they won't act that way and they won't feel that way, because it literally disconnects the trauma and the emotions, and it's 1 or 2 sessions and it's set. And I've done it after the training, I've done it on young kids, I've done it on adults, and it has almost immediate response.
I stand to correction, but I don't think we use it if somebody's psychotic in the first week.
No, you can't use it psychotic, but you can't use any therapy in psychosis. You need to have some stability before that. But they just said don't do it on court cases, because nobody will believe that they went through something bad.
Yeah, it makes sense.
I had a recurrent dream from my epilepsy, and I did the BWRT on that recurrent dream. And I was just like, what? So it's only by actually doing it that you realize how much difference it makes.
Mm. And we don't have a whole lot of time, and I'm pretty sure Dr. Thea's evoked a lot in all of you. So please feel free to ask questions or to share.
I think the most difficult part is the part where I tell you that you shouldn't be perfect. Because to tell parents that you should allow your child to suffer is quite difficult.
Mm.
I think that it's one of the most difficult things to do is to allow your child not to be perfect. Allow your child to make mistakes and to not rescue your child.
I think, Tia, we often use the excuse that we can't because of the drugs and we're scared they're going to die. But I think we have had a certain amount of trauma as families, where we also have selective memory. And they were doing this and we were granting them permission before they started using drugs, or in the early stages of them using substances. So the truth is, I often say to our patients' parents, your kid had your number. From day one, birth, looked into those eyes and saw, I'm going to walk all over you. I'm going to get whatever I want. And if they shouted enough, repeated the shouting enough, threw enough of a temper tantrum, we would give in. And I think, and we still hear it, and I often have to correct people and say, he's not a baby, he's not a child, he's an adult. She's not a baby, she's not a child, she's an adult. And that requires what you said earlier about the families might need to get help. You know, we've gone through trauma, and, you know, I don't think families go through PTSD unless they get assaulted and attacked and shot at. But living with an addict is very traumatic. And we will go to any lengths to get them help. Tomorrow, my phone's going to be ringing for all the patients getting BWRT. But how many of the families are going to say, hey, I might need some BWRT?
Yeah, I think often families need it. And it's interesting, when it got set up until the age of 2, you need to protect your child. And from the age of 2, you should start allowing him to make mistakes. So the protection is till age 2. And then, of course, you won't allow a 3-year-old to run in front of a truck, but you should start allowing them to make mistakes. BWRT, they've got a website, the South African BWRT website, where all the therapists is. And if you have trauma, I strongly suggest that you find a therapist in your area and you go and see somebody. It is revolutionary. I've seen a lot of changes in people, and people stay healthy. Up to 6-7 years later, they're still healthy on it. It's not a short-term thing when people are short-term and better. And I don't do it only for trauma. I also do it for difficult work situations, grief, etc. I do it for other things as well. And there's adequate research on other things as well. It started with trauma, but they did some good research on the others. And I strongly suggest that you do go for that. And allow your child from 2 years old to make mistakes. And you have to allow your adult child to make mistakes. Because I get phone calls and the patient is 30 or 40 and it's like, I can't do this to my child. And then I just go, it's because you protected him that he doesn't have any sense of right and wrong. And we like to protect our children. You know, we love them. But we have to realize that stepping back and allowing them to make mistakes is actually going to make them happy people. Complete protection isn't making people happy.
I think when we come to terms with the fact that when we help our kids, particularly our adult children, in an unhealthy or inappropriate way, we're actually insulting them. Because we're saying to them, I don't believe you're capable. I don't believe you able. And I'm giving a message of that you're not worthy to grow up and take responsibility. So I think when you start looking at it that way, it like hits you. I do love him, so maybe I should let him make his mistakes, take responsibility, and get help for myself because I need it sometimes before they do. There's a question, what should one...
BWRT is given by a psychiatrist, a psychologist, or a counselor. There's different levels, so there's different intensity levels. So it will cost whatever the psychologist or the psychiatrist or the counselor charge. It will be a session with one of them. So, of course, my sessions is much more expensive, so it's really not worth it to do BWRT in my office, but it's definitely worth doing it in a psychologist's office.
And it is covered by medical aid?
It's normally completely covered by medical aid because it's like going for a normal therapy session. But you just need to go to somebody that has the training.
And generally people advertise that they've done the course. So not every therapist, every counselor.
Yeah, go to the website, the BWRT South African website, and see which people have done the course. Because they have a list of people that's done the course and what level they've done. It's really worth it because therapy that can take 10 or 20 sessions can often be done in 2 or 3. The trauma talk therapy often takes 10, 20 sessions. BWRT, it takes 3.